Yep, the recordings. But I think the recording will only be available in about a year. Is that right, Pratham?
No, not yet. Sorry, not yet. It will be available in a week's time. So,
Okay.
if you're a MedSoc member, you'll get the slides and recording available by next week. If you're not a MedSoc member, you'll get it in a month, in a 1 month, not a year, on the MedSoc YouTube channel. Um, Details about that will be at the end of the tutorial.
Yep. Thanks. So I'll just make a start now. So for the interactive component of this tutorial, can I ask everyone to join at Menti, like every single one of you? And please write in the chat if you have any problems with that. Just allow for about 30 seconds for you to get that out. So I'll leave the code up, and I think I'll just um, begin. So today we're talking about chest pain, and that's a presenting complaint. And the first thing you want to do when structuring your response to how you would react to a patient having chest pain, or any presenting complaint actually, is think of it as history, exam, investigations, and management. I just had this hammered in me, like from so many consultants. I think they really prefer it that way. Um, so it's quite different from the preclinical way of thinking about it. But I'm going to be structuring my talk in this manner, and we'll start with history. And we'll be doing this case. So a 68-year-old man comes to the A&E with bad acute chest pain. And since we're talking about the history, let's go through what we would like to ask him. But to know what we're going to ask him, we also want to think about what kind of differentials we want to think about. So one way to start um, coming up with differentials is to think about what is in the chest because he's having pain in the chest. We want to think about all the possible systems that could be affected in this area. And if you could just pop that onto the Menti slide and we can take a look at what everyone thinks. Uh, so far I'm seeing heart, lungs, breast, gastro, cardiac. Yeah, these are all great answers, and that's what I would also say. Lungs and heart being the most major one, but gastro is also one of them. And that is because sometimes people might be having epigastric pain, but it's quite close to the chest. Uh, could be both. But the most important one is the heart. Um, so we'll start with that. Now we go on to the next question. What are some cardiac causes of chest pain? MI, ACS, angina. Yep, so yeah, ACS, angina, MI are pretty similar. And we also have pericarditis, PE. Yep, I would think those two are the biggest, most life-threatening conditions. But one really important one that you don't want to miss is aortic dissection. Some other ones are also cardiac tamponade, valvular disease, cardiomyopathies like Holcomb. Um, This might seem quite rare, but actually it comes up quite a lot, and it did for Arlovsky last year. And myocarditis is also something that can happen after a viral infection in a young person. Um, oh, by the way, I think the Q&A is on for the whole session, so if any questions, you can just put them in, and I'll talk about them when I have the time. So the next two systems that we want to talk about is respiratory and gastro, and we're going to do the same thing. So what are some causes of chest pain in these other systems? So someone said PE just now, which is basically rest, so I'll take that. Yeah, triple A, those are good. Pneumothorax. Yeah. I really like the responses, by the way, so far. Please keep it up. Um, pneumothorax. Yeah, I didn't think about anaphylaxis actually. That's really um accurate, I would say. No, it's not super pathognomonic of um anaphylaxis, but it is possible because you're having breathing difficulty. The ones that I want to talk about today are tension pneumothorax, PE, and Boerhaave syndrome. So these are the most life-threatening ones that we don't want to miss, and that's why I'll be going through these conditions. But some of the things, biliary colic, I think someone said something about gallstones just now, so yeah, that's correct. Gastric reflux is a quite benign cause of chest pain, as is peptic ulcer disease, and some other common differentials you might encounter in medical literature, costochondritis and anxiety. So costochondritis would be like if you've done quite a lot of physical activity, like you went to a yoga class, you did lots of gardening, and the next day when you breathe in, um, you feel chest pain in your ribs, and that can be commonly confused with pleuritic chest pain, but it's just not nearly as dangerous at all. And anxiety can also cause all sorts of symptoms. So just because some people might not have done their gastro rotation, Boerhaave syndrome is when you throw up a lot, like let's say an alcoholic, they because of all that throwing up, the trauma causes the esophagus to rupture. Yeah, so that's obviously not good. Okay, let's move on. Uh, so all those were more common in no, in older patients. How would your differentials change if the person were younger? I didn't create a separate slide for this, but yeah, I can see some new ones. I think asthma was one of them. Yeah, I can't see it very clearly, but thinking along the right lines. So, for example, if it's a 25-year-old woman on the combined oral contraceptive pill, you'll be thinking, firstly, 25-year-old woman, so less of the age-related diseases like ACS, but those are caused by the accumulation of plaques over the years. So that would be low down on differentials, but instead, um, thinking of like PE, things that can happen at any age. And obviously, combined oral contraceptive pills also increase your chance of having a thrombotic event. So, oops, yeah. PE, pneumothorax, and perhaps cocaine-induced coronary spasm. For pneumothorax, it's even more if it's a tall and thin young man. Marfan's is one of the key uh, risk factors because the connective tissue in the lungs become much weaker. Okay, yeah, that's just a reminder for myself to use Menti. So this is um so firstly, what kind of questions would you like to ask him? So just some ideas of like full questions using Socrates as a model. Sorry, I can't really see. Going to switch over. So, What's going on? Okay. I believe. Ooh, sorry, it's really annoying. I'm just going to read. I won't be screen sharing. Yeah, these are all good answers. Think you want to be careful about asking like, is it crushing pain? Because like that's kind of you would want to invite them to describe it in their own words first, because everyone's experience is different and don't want to put words into their mouth. That's how you end up with patients just saying yes, yes, yes to everything. So just keep that in mind. Open questions first, and then if they can't describe it, then give them options. Associated symptoms, those are very good. So shortness of breath, swelling, dizziness. Yeah, so all of you are on the right track. Thank you so much. Someone said burning pain. I'm not sure why you would say that. Maybe is it because of the gastric reflux? But even if it's a gastric reflux, I think you can still use dull and sharp. Those are still applicable. Oops. Share screen. There we go. Okay. So now I would like you to match the correct presentation with the likely cause. So if we can just start with the first one, like central sudden onset crushing radiating towards the jaw, and just put a pin in what you think is the most likely. So I see a lot of answers for MI and ACS. That's correct. See some in aortic dissection as well. It's possible, but because of the radiating towards the jaw, you would think more of a MI. Let's go to the next one. This one. Yeah, correct. This that would then be more suggestive of aortic dissection. Really good, guys. I'm just gonna move on to the next one. Words of inspiration was lying back compared to leaning in front, which we will also call pleuritic chest pain. So most of you all had chosen this option, which is correct. Someone said costochondritis. So yeah, these two are quite confusing, but I would say costochondritis would not be worse lying back. Yep. And next one again. Sharp, worse on exertion associated with breathlessness. So a bigger spread of results with this one, but most of you have chosen stable angina, which is correct. So stable angina basically means that when you're at rest, you have no pain, but once you start exerting yourself, walking, it gets worse. That's why yeah, it's worse on exertion. Okay, second last one. Sorry, let me reset the results again. Yep, let's go. Yeah, costochondritis, that's correct. And for the last one, I think I've already given the answer just now. Younger patient after viral infection. Yeah, myocarditis and not costochondritis. Yep. I assume that's just because I reset the results slower. Hey, they're really good, guys. So next slide. What kind of questions would you like to ask for the history of presenting symptoms, oops, uh, and systems review. So just what kind of questions do you want to ask them now? Have you been vomiting? Yeah. Do you have nausea? Any cough or hemoptysis? Mm-hmm. So if it helps, instead of thinking of like just to narrow it down, just think of it as the systems again. So cardio symptoms, rash symptoms, gastro symptoms. What do you want to check? Like I'm gonna go through it, but basically for each system, just think of like three symptoms you would like to ask about. So yeah, I see some systemic symptoms as well, the usual like fever, night sweats. Yeah, that's good. So let's start with cardio. Um, Cardio-specific symptoms are shortness of breath on exertion, because of as I mentioned just now, angina is only on exertion. And shortness of breath is something that's um, quite useful in uh, narrowing down your differentials because, for example, heart failure, you can get shortness of breath due to the fluid in the lungs. Palpitations, you always want to ask about. Syncope, because cardiac syncope is quite common. Peripheral edema and swelling, orthopnea, and PND, which are all related to fluid overload in heart failure. And one thing that you often like to ask about is also, has this happened before? For the systems review, so for respiratory, you would again ask about shortness of breath, so you don't only need to ask this once. Cough, and you bring up any blood with that cough, any sputum, what color is it, any noisy breathing, you would say that instead of a wheeze. Again, vomiting, any blood with that, and jaundice. Standard things that you want to check: fever, night sweats, weight loss, and fatigue. So regardless of which system you want to uh, ask about, you would always want to ask about that. The rest of the history, pretty standard. I would suggest to ask more uh, earlier than they usually suggest because you run out of time in an OSCE. You ask about past medical history and also about the drugs they are on at the same time because often they're related. Also, don't miss out allergies, family history, particularly important for cardiac history. Um, you want to ask at what age, because if someone's mom died of a heart attack at like 75, it's probably not genetic. Um, it's probably just old age related disease. Um, and social history, occupation, living situations, smoking, which increases the risk of any cardiac disease, drinking recreational drugs like cocaine could cause a coronary spasm. Um, so someone asked, is PE pain not worse leaning forward? Yeah. Wait, I'm not sure where I suggested that it doesn't. Um, yeah, so oh, that's what you mean. Okay. Hmm. I will come back to you. Uh, so now we'll start with examination. So what are some signs that you might be looking for in our cardiovascular examination? And while you're doing that, I will check. Yeah, so I've checked and I'm pretty sure it's relieved by leaning forward, so it's worse lying back. The reason is that there's less pressure on the pleura when you're leaning forward. Okay, so just reviewing the responses so far, somehow everyone does not forget clubbing. That's about the least seen thing in a real examination, but fine. Um, okay, so first you would like to start with inspection, right? So just from a distance, looking at the patient at the end of the bed, and you would like to look for any difficulties breathing, as someone has said. So if they are having difficulty breathing, like breathless, you can note that as a um, general inspection. They might also look pale. That's about all you can see from the end of the bed, really. So when you inspect, you start with the hands. And as you have mentioned, Janeway lesions, osseous nodes, splinter hemorrhages, these are all things that you will be looking for. You can also look for xanthelasma. Um, all right, so why I didn't mention those things is because those are more relevant to infective endocarditis, not really for the conditions that we're discussing today, but you will also look for those. Um, so the pulse, you can tell a lot of things from it. You can tell if it's fast, if it's slow, um, if it's unequal in both arms. That's why you have the radial delay, water hammer pulse. So when you feel the brachial pulse and you quickly lift up your arm, their arm, sorry, and you might be able to feel a tapping. Um, Pulses paradoxus is when you inspire, and I think it slows down. Yeah. Um, you can also have xanthelasma, which is cholesterol deposits in your hand. They might also just feel clammy and sweaty, and you just can tell they're not feeling well. So face and neck, you might be able to see a raised JVP. I've seen JVPs that are like all the way up the ear. Um, that was due to tricuspid regurgitation. And if you're interested enough, you can look for, you can study JVP waveforms, if you're interested. You can also have a cough. Untreated heart failure causes a pink phlegm because of the blood that's in the phlegm. So heart sounds, so just auscultating for any murmurs or muffled heart sounds for tamponade. You also need to listen to the lungs for any fluid as well, because that would suggest some sort of failure in the left ventricle. And also feel for sacral and pedal edema. Right. Um, so we're going to start with ACS. Sorry. I'm just going to talk through the conditions right now, so you can take a break from NT. So the physiology is ACS, is that you have fatty deposits in your blood vessels, in I think, yeah, the wall of the blood vessels, and this is called atherosclerosis. And over time, you have plaques, and there's a whole inflammatory process which I'm sure you learned about in pre-clinicals. And when this plaque ruptures, or when maybe there's even an additional blood clot on top of it, it will obstruct blood flow. And when this happens in the artery supplying the heart, then you have a really dangerous situation. So the heart, um, the wall of the heart, but the one that I'm most worried about is the myocardium. It loses blood flow and starts to die. So I think this damage can be irreversible, which is why you need to revascularize the heart quite quickly. And depending on how much of the artery is blocked, you have different syndromes. So if it's only partial, it's unstable angina or NSTEMI. But if it's a total occlusion, which causes the entire heart wall to be infarcted, which is why it's called transmural infarct, it's STEMI, which is more severe. And you see later that our management is more acute. I don't know how I would say that, but you would want to treat it more quickly. Yeah, so unstable angina. Right, maybe I should explain what troponin is first. So troponin is an enzyme that is released. Yeah, I say it here. Troponin is an enzyme that is present in cardiac and skeletal muscles. If they ask you what kind of troponin specifically, it would be TNI. Because the heart muscle dies, the cells release troponin enzymes into the blood, and that's why when you take bloods, you can detect it. And if there's a dynamic rise over time, that would suggest that actively you're having this infarct. But in an unstable angina, there's no real infarct, although there is that partial occlusion, which is why you're having the chest pain. But there's no troponin rise. Because this is confusing, I'm just gonna go back. Right, you just want to think about, just really want to remember that there are 3 types of ACS, and the way to differentiate them is that unstable angina has no troponin rise, the other 2 do have a troponin rise, and only the last one has a ST elevation or new onset left bundle branch block. Hopefully that's clear enough. So if you have any other thing on an ECG, some other changes in ECG, then it would be considered an NSTEMI. But NSTEMIs do have a troponin rise. Okay, so you would have sudden onset, central crushing chest pain, radiating classically up the jaw, but also down the arm. Do note that silent MIs do occur, more commonly also in diabetics. So they might just feel really unwell, but they don't have the classic symptoms of chest pain. I think it's also more common in women to have a silent MI. So do not directly rule an ACS out just because they don't have the classic chest pain. You also want to ask, note down if in the history they have cardiovascular risk factors, such as previous diagnosis of angina, or previous MI, hypertension, diabetes, hypercholesterolemia, history of smoking, anything like that. On examination, you just want to look for the risk factors as I've mentioned just now. So cholesterol might show up as a xanthelasma, xanthomata, or corneal ulcus, although you might want to note that in old people, a corneal ulcus is quite common. Atherosclerotic vascular disease might cause weak pulses, peripheral cyanosis, cold peripheries, basically all your on your vascular rotation, you learn all these signs. And arrhythmia, like a bradytachyarrhythmia, might also be suggestive of something going wrong with the heart. And for the investigations, and you would like to do some bloods to measure troponin, an ECG, an echo, and also a chest X-ray, just to actually, I think it's more important just to rule out other differentials. So it's better doing chest X-ray. And just a quick sidetrack into heart failure and the difference between right and left, because I found it quite useful to learn the difference. So heart failure is the failure of the heart to pump enough blood to meet the body's demand. Because we are short on time, I think we can just read this. And the difference is that the left is more of pumping the blood from the lungs into the rest of the body, whereas the right side of the heart pumps blood from the rest of the body into the lungs. So if the left side is not working well, it's the lungs that get backed up. But if it's the right side of the heart that's not working, the rest of the body gets backed up. So like the liver, yeah, you might have an enlarged liver, or just like overall fluid overload in the ankles and the sacrum, raised JVP as well, because this vein goes all the way up there into the neck. You can have ascites. Whereas all the lung symptoms that you commonly hear about, these are for the left heart. Yep, I hope that is clear. So we're gonna start on our first SBA. If you could just pull up your Menti on your phone again, we could just have 2 minutes, 1 or 2 minutes to attempt this question. Sorry, I know it's quite a tough one. Just guess. I'm going to wait for about 10 responses. Okay, so I'm sorry, it's not actually related to what I just discussed. Um, the answer is actually CT cap, because with a widened mediastinum, you're thinking about aortic dissection, which I'll now talk about. I know a lot of you chose echo and troponin because I just mentioned it, but yeah, I'm actually going to talk about this right now. Okay, so this is a really fatal condition, which is why we're talking about it. With an aortic dissection, um, you basically have a tear of the tunica intima. If you can remember the layers of the blood vessel wall, you have the intima, media, adventitia. So this is the innermost layer. There is a tear in it, and that causes blood to enter it and form this false lumen over here. It's really important to remember this term, a false lumen. And because of this, it can cause problems in the chest when it becomes bigger, and also obstruct blood flow from the aorta into other organs. This tear can also keep becoming bigger and bigger and move down the aorta. Yeah, so the key signs that you so yeah, this is just to demonstrate how it can become bigger. Yeah, so it tracks down the length of it and can potentially go all the way down. Yeah, so the first sign, most important, is a radial delay. So in one arm, the pulse might be a little slower than the other one, or just completely absent. Depends on how severe it is. And just to explain why this happens, it's because as you remember, the aorta has a lot of branches, and they go to different parts of your body. So the right brachiocephalic trunk goes this way, and that is the common carotid and the subclavian. So if the obstruction is here, for example, then one side is unobstructed, but this side is obstructed, so it becomes lower. Because of this, you can also have lower blood pressure in one arm, and this difference, if it's above 20, it would be considered quite suggestive of aortic dissection. Can also have early diastolic murmur, as I mentioned in the SBA earlier. Aortic regurgitation happens because the aortic valve might be affected if the false lumen tracks all the way here. And because of the mass effect, the pleural of the lung might also be affected. And the most important risk factor is hypertension. The others you can just look through on your own. And for the investigations, as was the answer for the last SBA, it would be a CT cap, because then you'll be able to see a false lumen, as you can see right now. And if on a preliminary chest X-ray you see a widened mediastinum, you will also proceed to do a CT angiography at this point. And if the patient is too unstable to move to the CT scanner, you would then do a transesophageal echocardiogram. Okay, so the next SBA, about 2 minutes for this one as well. Okay, so the majority is correct. It's a pain that's worse on taking a deep breath in. So some people have mentioned the weight loss. So it's not actually related to her cancer becoming worse, but it's actually because the surgery predisposes her to having a pulmonary embolism, which is what we're going to talk about now. So I just want to make sure all of you remember at the end of the session that if they have a risk factor, like a long lie, meaning a period of immobility, surgery, or if they were taking the contraceptive combined pill and they are showing shortness of breath, and on the chest X-ray you can't see anything, please think of PE. Because again, I got that wrong in our OSCE and I regret it a lot. So a clear chest X-ray is characteristic of this. So what happens is that because you have surgery, immobility, or malignancy, anything like that, it increases the chances of you having a blood clot. And this blood clot can travel to the lungs and impair perfusion to the lungs. That's why you will have shortness of breath because your lungs are not working properly. You can also have pleuritic chest pain, which is worse on inspiration and worse lying back, relieved by leaning forward. Can also get hemoptysis. It's, I put this plus minus sign because sometimes it's not necessary for a diagnosis to be made. You can just suspect it if there's acute onset shortness of breath. And I remember there was a very specific sign that you might be able to find online for PE, but it's very uncommon. Most likely you'll find a sinus tachycardia. You can also find hypoxia. If you do oxygen saturations on the basic ops, you would see hypoxia. Yeah, as I said, sometimes they would just have shortness of breath. So this is where the PERC criteria and Wells scores come into play. So if they even have one of these criteria, you want to consider PE. and you can find this yourself on PassMed. But what I want to just highlight from here is that if it's unlikely, you would do a D-dimer, and this is a more non-specific blood test, because there are many things that can cause a D-dimer, but it's a good preliminary test. And if it is likely, then you would go straight for a CTPA, which is a CT pulmonary angiogram, just to look at the blood vessels in your heart. And if you can't find anything, then you want to do a proximal leg ultrasound, because that's where a blood clot is likely to form in your leg, basically a DVT. Yep, what I just said. Okay, next SPA. What is COCP? Combined oral contraceptive pill. And whoever said sorry, just don't say sorry. PassMed says VQ scan for PE also an option. Okay, so you would do a VQ scan if the patient had renal failure. So because of the contrast that's used in an angiogram, it might damage the kidneys further. So in practice, you would consult with a renal doctor first. But yeah, renal failure, think of a VQ scan. What is a VQ scan? It's a ventilation perfusion scan. So if you remember the VQ ratio, I've never seen it being done like in real life, so yeah, that's about it. But I guess because if there's a PE, ventilation will go down. Oh wait, sorry, perfusion would go down. Yeah, that's what I meant. So that would be Q. Okay, most of you have gone for stony dull percussion notes. So that is for fluid in the lungs. So the answer is actually, oh, I'm so sorry, guys. None of you all chose that. Okay, let's just quickly go through this then. It's actually a pneumothorax. Okay, let's try to go through this in greater depth. So, shortness of breath with chest discomfort, but it's not a PE. Yeah, so basically you you should see COPD as a risk factor for pneumothorax, and then from there, if you have desaturated oxygen saturations and it's not improving on oxygen, you would suspect a PE, and a PE would be sorry, a pneumothorax, and a pneumothorax is air inside the lung, which would cause hyperresonance when you percuss, because it contains even more air than normal lung tissue. This looks a bit complicated, but yeah, let's just try to go through this. So the most fatal one is tension pneumothorax, and this is where there's a one-way opening and air enters but cannot escape. So this is where you would have a tracheal deviation away, and this also causes a mediastinal shift. This can also affect the heart and cause a cardiac arrest, which is why it's so dangerous. And also, you can imagine there's just non-stop air going in with nowhere else to go. Some other types of pneumothorax would be a closed or open one. If it's a closed pneumothorax, it could be from like COPD, as we just mentioned, or we could have a traumatic impact. So basically, you have this hole in the lung in the inner lung tissue. So when you breathe in, air goes in. But with an open pneumothorax, the hole is in the outer layer. So this is usually due to trauma, like in a car accident. So air is coming in from the outside. So some risk factors, smoking, Marfan's I've already explained just now, asthma, COPD, just any lung condition, chronic condition would likely compromise the integrity of the lung tissue, if that makes sense. So if you have tension pneumothorax, you would tend to have pleuritic chest pain as well. And on examination, you can see the tracheal deviation, hypoxia that worsens with ventilation because you're encouraging even more air into the pneumothorax. Accessory muscle use is just like respiratory distress. If you're going into shock, you would have a sudden drop in blood pressure. As we mentioned just now, hyperresonance on percussion. And or in an area that you have pneumothorax, respiration would no longer be occurring. So you would just have no breath sounds in that area, and that would be quite worrying. For your investigations, if it's a tension pneumothorax, do not image it and go straight to an emergency needle decompression. I'll explain this later on in management. So just to quickly go over the Boerhaave syndrome, you can see here that this is the esophagus and it has ruptured, causing the contrast to just go everywhere else. This is a rare but highly fatal transmural esophageal tear, usually after prolonged vomiting. So they would have something suggesting vomiting in a history, and these are some things that can happen as a complication of the esophageal rupture. On the chest X-ray, you might see some air in the mediastinum, and I don't think they would ask you to interpret that in a real chest X-ray. It's just really hard to see as a student. But you know that the definitive investigation would be a CT contrast swallow, as I've shown here. You'll also do an ABG, which might show metabolic alkalosis and hypokalemia as a result of all that vomiting. We would like to treat that with antibiotics, and also repair of the esophagus. Okay, finally, we have gone to investigations. So what kind of investigations would you like to ask for? I'd like to think about this in terms of layers like an onion. So the most basic one to the more complicated one. So bedside first, bloods, and then finally sending for imaging. Sorry, does anyone have trouble entering your answers? Oh, there we go. Chest X-ray, CTPA, and troponin. Yeah. But some more basic ones. Yeah, ABG, ECG. Someone asked, so you would only really do that to check the kidney if there's a big PE. Sorry, I don't really know what that means. No, it's not to check the kidney. It's because they have renal failure, so you don't want to use contrast, which you need for a CTPA. So instead of doing a CTPA, you would do a VQ scan, which doesn't need contrast agent, but you're still checking the lung, not the kidney. But you're right that you would need to check the kidney before doing a CTPA. So actually, I was going to say in the investigations, you would like to do a UNEs, urine electrolytes, just to check for renal function. And then if we are sure that there's no issue, then we can proceed with the CTPA. Yep, so hope that makes sense. VQ scan will only really be useful for the lungs because it's only the lungs that has ventilation. I think the question is confusing. Does it mean which findings likely to support the diagnosis of... Yeah, so it's a two-step question. You think of what is the likely diagnosis in this case, and what investigation would be able to definitively or point you towards that diagnosis. Blood pressure, yes, that's one of the basic obs, and O2 sets as well. So yeah, that's good. So bedside, you want to do vitals and basic obs, which would include the blood pressure and O2 sets. You also do a ECG, which is very easily done by the bedside. For the bloods, you always do a full blood count and CRP. You might find some anemia or infection that's going on. So even if you have a diagnosis in mind, it's good to do FBC. Also, UNEs, renal function is important for the CTPA, the ABG, troponin. To look for dynamic rise, you repeat it 2 hours later. You do a D-dimer to exclude PE. Look for some risk factors for ACS, which is HbA1c, CBG, lipid profile. And also if you're suspecting pancreatitis for gastrocause, you would also do a serum amylase lipase imaging, as you have mentioned, and do a chest x-ray, but you also do an echocardiogram. That's really important to find like ventricular function. And we are going to move on to ECG interpretation. Going to try to do this really quickly. I noticed that the responses are decreasing, but I would like everyone to participate in the ECG, if that's fine. Yeah, it's a really important skill. So how do you present an ECG? Let's not get someone to try. Don't have time for that. So you always start with the patient details, like who are they, what's their name, what's their hospital number, what date is it, what time is it, and the structure generally would be rate, rhythm, and axis. Rates, there are two methods for it. You can either take the gap between the QRS complexes and divide it, or you can just count the number of QRS complexes in a whole 10-second strip and then multiply it by 6. The second one you would use for an irregular rhythm. And then move on to rhythm, and then axis. Axis, I just wanted to quickly explain. So these are different like leads, and by using certain leads, you can tell if it's in the right direction. So if I just jump ahead and show you a real ECG. So you can use 1 and 2 to determine the axis. You can have them so this is normal axis, but if they were pointing in different directions, some people use the mnemonic like lovers leaving, so that's like left axis deviation. But if they're like pointing towards each other, then it's lovers returning, which is a right axis deviation. But if you want to think about like the theory behind all of that, then you would look to this diagram. So if 1 and AVF are both positive, that's normal. And if AVF is negative, but this is positive, then you would look here instead, towards left axis deviation and so on. You can look this up. It really helps. And then afterwards, you move on to describing each particular like feature of the ECG waveform and do it systematically from the P wave to the PR interval, etc. So let's go into that. It's good to mention that a sinus rhythm is present. So if a P wave is always followed by a QRS complex, you can just say, yeah, that's a sinus rhythm. The right atrium usually depolarizes before the left atrium, but if there is any disruption in that, you can have like P mitrale or P pulmonale. So that's why you have a notched So basically like the P wave kind of separates a bit because this LA enlargement causes the LA to need a little bit more time, and that's why it's later. That's why you have two things. And yeah, if the RA is enlarged, you would just have a higher amplitude. For the PR interval right here, if it's prolonged, you would be thinking about heart block, and there are many different types. Not sure I have enough time to go through them, but very important to go and learn that. QRS complex should usually be 3 small squares wide, and if there's any broadened QRS complex, you'll be thinking if the generation of the ventricular contraction has moved to like below the AVN. Basically, it means that maybe there's some sort of heart block as well, causing the generation of the impulse to start from the ventricles themselves rather than from above the ventricles. For the ST segment, as you have mentioned, ST elevation was suggested as a STEMI. That's really all you need to know. You might have a depression in opposite sides of the STEMI. I'll explain on the next slide. So basically, like, let's just go there first. So like each of the leads corresponds to a different area in the lungs, in the heart. So these leads V1 to 4 suggest that you have, more pointing towards the territory in the heart supplied by the left anterior descending. So this is the anterior side, but sometimes the opposite side of the heart would then have depression instead. So this is elevated and that is depressed as a result of that. If that makes sense. So that's what I'm trying to say. So the QT interval is next. There's certain drugs and certain conditions that can cause a prolonged QT interval. I think it's just a lot to memorize. I personally did not memorize it, but you could. When the QT is prolonged for too long, it could lead to something called a torsades de pointes. You can Google that. Basically, like it's classically described as a polymorphic like tachycardia. And lastly, for the T waves, if you have tall tented waves, it's characteristic of hyperkalemia. And T wave inversion, on the other hand, is indicative of ischemia. So hopefully that was a good overview. As I said, the anatomy of the heart is like the amount of the blood supply of the heart is quite useful. Still at this stage, you would want to remember like there's the left and right coronary, and the right side supplies the inferior aspect of the heart, and the left anterior descending is more of the septal and anterior leads, and for the lateral sides they are supplied by the circumflex over here, and also partly by the right coronary. And important to note that any type of ischemia can cause like similar signs to an ACS just because it also causes ischemia. So it doesn't have to necessarily be ACS to see something like that. You want to do more investigations. Yeah, so it might be important to remember that the AV node is supplied by the right coronary artery. So if you damage like the inferior side, um, you might also cause other like broad QRS because like just other sorry, bradycardia as well. Yeah, bradycardia and broader QRS because of the problems, right? So mm, if you could just attempt this question using what I've just talked about, I think I'll just wait for a few responses. Okay, so there's enough responses for that to be a trend, and I think the majority is correct. So it's 2-3 AVF. So 2-3 AVF corresponds to the inferior side supplied by the right coronary artery. And as I said just now, bradycardia results from that because of the disruption to the supply to the AVN, the atrioventricular node. So it's really hard. You just have to spot the bradycardia. Yeah, so let's move on to hopefully easier things. ECG SBA number 1. What do you think this is? So a lot of you have gone for supraventricular tachycardia, which is not technically wrong. The answer is actually atrial fibrillation, but it is a type of supraventricular tachycardia, so I would give you that. Um, so you're correct, it's narrow and it's fast. But it's quite important to recognize atrial fibrillation. So the rhythm is not regular. P waves not really visible, not really always followed by a QRS. So that's why we think of atrial fibrillation. Um, and it's characteristically described as an irregular pulse. But what I wanted to also say is that there are other causes. So other than an atrial fibrillation, you can also have ventricular or atrial ectopics. So they would look quite different on ECG, but when you feel someone's pulse and you feel like it's irregularly irregular, technically you shouldn't jump right to AF because you can still have ectopics that cause like random beats. And you can also have ventricular fibrillation, which is obviously quite dangerous and quite fatal, but still, theoretically, it would cause irregularly irregular pulse because the ventricles are not contracting simultaneously, uh, and not simultaneously, I mean, not in a coordinated fashion anyway. So SBA2, if you could just take a guess. Oh, sorry. I realize I have some questions in the chat. What is PND? Paroxysmal nocturnal dyspnea. That's when people say they wake up in the middle of the night because they're breathless. So like paroxysmal means sometimes, nocturnal at night, dyspnea, shortness of breath. What does dynamic rise in troponin mean? Yes, so it rises um from the time of admission to 3 hours, like it continues rising. That's a dynamic rise. Blood's BNP normally is like when it's less acute, um, like a chronic heart failure kind of thing instead of acute. Hope that helps. And back to this, a lot of people have gone for NSTEMI. I don't know, like I I think it's quite obvious that there is a STEMI here, like 2, 3, and AVF. ST segment is quite elevated up here. So that's what it is. If you would just, I mean, if you're one of the people who wrote NSTEMI and you want to discuss that, you could ask again. This is the next one. Okay, so going back to the previous question, oops. Maybe some of you spotted this ST depression and thought it was NSTEMI. So basically, this is a reciprocal depression. As I mentioned just now, elevation in certain parts can cause depression in the opposite side. So that's what's happening here. Yeah. Okay, so most of you have gone for LV hypertrophy, and I have again tricked all of you. It's actually a posterior STEMI. So a posterior STEMI will also have tall R waves. So in the septal leads, anterior leads, you would tend to have a tall R wave, and that's because it's an opposite reaction. Posterior STEMIs can only be confirmed by doing posterior leads at the back, V8 to V9. And then over there you see a ST elevation. But in the opposite side of the heart, which is the anterior side of the heart, you would see this instead, which is a ST depression, a reciprocal depression, as well as tall R waves. I guess what differentiates it from LV hypertrophy is that you can see the reciprocal ST depression, and then you would it won't confirm your diagnosis, but you would just do an additional posterior lead ECG to confirm it. Right. SPA4. Last one. I thought you guys might be ready for an open-ended answer. So this is quite hard, so I guess I'll just talk through. Over here you have a widened QRS, and that's why you want to start thinking about like heart block or bundle branch block. Over here, yeah, you can see it quite clearly. There's a broadened QRS, and also the axis is all wrong. The AVF is negative, or using the mnemonic, they're pointing in opposite directions. So there's a left axis deviation. And from that, you can also start thinking about LBBB because with the bundle branch block, if it's blocked at the left side, there'll be a left axis deviation. Yeah, so if anyone knows the mnemonic, William Merrill, so left bundle branch block would be William. That would mean like a W over here and an M over here. This is also called a R prime complex. So like in a QRS complex, you see two R's, two peaks. Yeah, I thought you might miss it, but yeah, majority actually got a left bundle branch block. Good job. Yeah, this is what I was talking about. William Merrill. Yeah, and also note that this is also a sign of ACS and it could be a STEMI. All right, so finally in management, um, okay, I'm just going to be talking through everything. So if you have any questions, just put them in the Menti or in the chat. Um, Management, it's quite an acute situation, so you would want to do the ABCD approach. That's airway, breathing, circulation, disability, and exposure. It's important to quickly stabilize the patient. Um, you would be much more familiar with this later on in the year. Um, Important acronym is MONA, morphine, oxygen, nitrates, which is a glycerin, no, glycerol tri, no, I don't know what the long, I used to know this, but yeah, GTN spray. Um, it helps relieve, like, dilate the heart vessels. And there's also aspirin, 300 mg. But what's important to remember is that morphine and oxygen are not used like always. Morphine is only if they're in pain, and oxygen is only if their saturations are below 94. Um, so with an ECS, you need to remember this thing called PCI. What it is basically like the stent that you probably have heard about. You put a stent into the blood vessel to open it up again. And the other option, if you can't do a PCI within 2 hours, which is important for the more severe STEMI, would be a fibrinolysis. So you would give them something called alteplase. So I'm just going to elaborate more about this PCI. It's usually inserted through the radial artery, so literally just in here, they only make a small opening and they go all the way up. So they used to do femoral as well, but because it's in a more inconvenient place, it's associated with poorer clinical outcomes. You will also give some other like anti platelets during this procedure. Just thinking about like possible OSCE situations. How would you consent a patient for PCI and what does the patient need to know? Just have a think about that. Okay, so you would like to tell them what does it involve, of course, but also like the benefits and risks. Um, so just to tell you right now, the benefits would of course be like um saving them. But some risks might also be bleeding, because it's an endovascular procedure. You're putting a wire into the vessels, there could be a rupture, and of course, infection is possible, and the contrast might be damaging to the kidneys. Um, and for the fibrinolysis, you will want to monitor their condition, and if it's still going on after 90 minutes, you would send for a rescue PCI. Okay, so for the NSTEMI, it's not as severe, so you don't need to do the PCI so quickly. You would try to stratify with this gray score. Even I don't know what is in this, but basically it means the 6 months mortality. And if they are at high risk of mortality, you would like to do it within 3 days. Um, but if it's worsening and they're hemodynamically unstable or like acute heart failure, you want to speed it up a bit. But if they're low risk, you can just manage it conservatively with ticagrelor, as well as these other things, and fondaparinux. So this is what I found for like remembering antiplatelets. Always you'll give aspirin because Mona just now aspirin 300 milligrams to everyone who probably has an ACS. If they're getting a PCR, you would give prasugrel. If they're having thrombolysis, ticagrelor, and if they are on anticoagulants, then you would switch it out for clopidogrel, because if they're already on anticoagulants, you don't want to overdo it. So that's why you switch it to a less potent version of antiplatelets, clopidogrel. Okay, so hopefully that was clear, and we're gonna move on to aortic dissection. The types A and B really determine how much of an emergency it is. So if it's A, it's much nearer the heart, it's a surgical emergency. you would like to do a aortic root replacement, and oh yeah, some cardiac complications that make it so dangerous are coronary dissection. That's when the false lumen tracks right into the coronary arteries as well and obstructs the flow. Then you would have ACS on top of everything. Um, but if it's a descending aorta, it's less dangerous. It's possible that the aorta might remodel itself over time. Um, but if, let's say, it affects the kidneys, like here, these are the renal arteries, I believe, and um, if there's end organ ischemia, you would like to consider surgery as well. And for both of them, you would give BP control. So labetalol is like a really powerful beta blocker to help control hypertension, which just to link it back, the most important risk factor for this condition is hypertension. You also give analgesia for the recovery because it's very painful. And for tension pneumothorax, as I mentioned, don't image, just go straight for the needle decompression. That would be with a wide bore, for example, 14J cannula. So the smaller the number, the wider the bore of the cannula. And after you do this, you like to follow up with a chest drain, which is which would more definitively get all the air out. And for the PE, there are various options. You could do anticoagulation or thrombolysis. So anticoagulation is usually with DOACs. You might see some other anticoagulants being used. It's either because they have these like comorbid conditions that cause consultants to use different options, or it might just be that consultant is not following the updated guidelines. So yeah, just remember DOACs. Um, the duration varies depending on whether they had risk factors or not. So if they had some risk factors, like they had a surgical procedure earlier on, then you can stop it in a shorter amount of time. Um, and one other thing to consider when prescribing anticoagulants is to weigh it against the risk of bleeding, which would be measured using the Orbit score. And let's say they are hemodynamically unstable. Um, so for example, more life-threatening severe PE would be a saddle PE, whereby the clot is obstructing both pulmonary arteries, so both sides of the lung are affected. You would do something called a thrombolysis, which is similar to what I mentioned just now with the ACS, so alteplase. Um, yeah. Um, so if you have a high risk of bleeding, um, or you're pregnant or you have aortic dissection, does not make sense to do this so quickly, and it could put the patient in danger. Just remember these factors, but obviously you won't be expected to know what to do at the F1 level. So this is a lot right now. We're basically done right now. I just wanted to mention like it's worth studying the complications of an MI. Um, and there's this mnemonic to help you, but I also found it easier to remember it based on whether it's a functional or structural problem. So like I just think, oh, which part of the heart is being affected, if it's the ventricular wall and like blood is leaking out of it and causing a tamponade, that's probably a free wall rupture, that kind of thing. So yeah, you can go through this on your own. Um, this is a feedback form. Please fill it out. It really helps us. And I'm going to jump back to this slide, but just quickly to mention, if you are a MedSoc member, you can get access to the Google Drive, get access to our slides, recordings more quickly. So yeah, but first fill out the feedback form.
Yeah, I think that's the end of the tutorial, guys. And if anyone has any questions for Xiao Wei, before you guys leave, any burning questions, if you guys are confused about anything or wanted anything else more answered.
I just saw a question. What was the answer to SBA 2? SBA 2 was an inferior STEMI. Hope that helps.
I can stop the recording now if anyone wants to ask a question and not be recorded when they ask it.
Oh, SB after that. That was a